generating tension. Somebody grab a pillow over there in the back. It's part of setting this up in a way that makes the patient feel comfortable. So the first couple steps are going to apply for anything side posture. And the only reason we do side posture manipulation is so we can use the thigh and leg as leverage. So that's really important. If you don't use that as leverage, there's no reason to have the patient in side posture. So first couple steps are going to apply anytime you're doing side posture stuff. If you contact the patient, then you don't break contact, or they fall off the table. I've talked about this with a lot of interns. People forget, and then they're doing stuff, and then they back up a little bit, and the patient's just like, oh, I'm going to fall off the table. Even though they're probably not, they still get that, and you don't want that to happen. So the first thing we need to do with all of these side posture manipulations is to flex the hip at least to 90 degrees. So I'm going to do that. Straighten that bottom leg out. So flex it to 90 degrees. And I'm keeping that there so you can just completely relax. If I didn't have her knee on top of my knee, basically, it would flop down a little bit. Some people are really floppy, and you do that, and then like, boom, down to the ground. And that would kind of mess your setup up. So here we go. And she's too far away from the edge of the table, so I'm going to grab her knee like this, and then scoot towards me, and I'm going to help. So it doesn't mean move the patient. You don't have to lift them up. Don't do anything weird. You're not reaching underneath them and lifting them up. Don't make sure that you're not manipulating or moving the thigh with your hands. You can do this easily with the knee if you need to, and if I need the other hand, I can go here. What I don't want you to get used to is a lot of this, where you're just doing weird stuff on their inner thighs, and just stay away from that. Some patients would be very uncomfortable with that. None of you will be. But you don't want to practice in a way that only you guys will be comfortable. If I need to move the thigh, I can easily do that. Pretty much from here on out, if I need to move the patient around, I'm going to do the movement. I'm not going to ask the patient to move. Because to do that, I would need to step away or break contact. She's kind of holding herself up on the table, but a lot of people wouldn't do that, or they would be really nervous about this position. So I made contact here. Now, if I'm going to break contact down here, then I should at least have contact up here. So the patient feels like they're not going to fall off the table. So that's really important. And then I take the arms, I put them like this, especially people with broad shoulders. You pull that bottom shoulder out a little bit to just give them a better base. That's another way that you can keep them from feeling like they're going to fall off the table. If that shoulder's underneath, they're less likely to feel like they're rolling over, because they can't roll over that shoulder very easily. This thigh is going to be really important for leverage. In the low back, the leverage creates rotation of the low back. In the SI joint, that leverage creates hinging of the SI joint. If the leg's back here, that minimizes that lever arm. The leg can be a little bit past 90 degrees if that's functional, and we'll get there when we start talking about ASs, but for the low back, we really just need it in here. Some people do this where they palpate SPs. They kind of flex the hip until the SPs move. That's okay, unless you're working on a really flexible patient and you're in the upper lumbars. Because what ends up happening is you don't get opening of the SPs until the knees, until they're biting their own knee. That's not going to be good. You're taking that lever arm and you're really shortening it. Plus, you're putting them in an uncomfortable position. I'd say for like L5S1, that's not a bad way of doing it. I don't necessarily do that though. The way that I localize where I'm rotating is just more low back rotation or more upper body rotation. And if I want the rotation to happen in the lower lumbars, I'm going to have a lot of upper body rotation to wring out that dish rag down to the lower lumbars, and a little lower body rotation to kind of tweak the tension. So if I'm going to focus on like L5, I'm going to keep the upper body right where it is. Her upper body's kind of rotated right now. I'm not going to rotate it much further than this, but I'm going to pretty much keep it there. So let's do this hand right there. I like to hold on to the elbow like this and my vector to keep the upper body rotated is not this way. It's not pushing into the patient, it's that way. Like that. If you push down like this, then eventually we're going to get ribs in there, and that's just not going to feel good at all. Especially if I were to do a thrust there, I could actually injure somebody. So, we're here like this. I'm doing lower lumbar tension. So my hypothenar eminence is going to be over where the mammillary processes are. This is a horrible position for me biomechanically, so I have to get everything here. So the way that I do that is keep the upper body right where it is, keep everything as torqued as possible, and then just roll everything over. Notice how if I do that, you kind of feel like you're going to fall off the table. Right. So I don't do it like this. I'm in here like this, and I just ratchet down. So I roll the patient, I pin them. Okay, that's not enough, so I got to roll. Okay. Now we're at where we need to be. You're not going to feel a lot of tension here because I haven't tweaked it yet. Now I can bring the upper body into rotation, push the lower body into rotation. Now we've developed a little bit of tension in there, correct? Mm-hmm. Are you feeling the ribs? Mm-hmm. Okay. Somebody with your type of P to A diameter, meaning not very big, I have to be really careful about the ribs. Some people, depending on where you are in the lumbar spine, you're going to feel it no matter what, but you want to minimize it as much as possible. If the patient is uncomfortable in their ribs especially, and then I thrust on that, that wouldn't be a good idea. So that was rotating and kind of, you can kind of see, if you look at the spine, it's kind of rotated, like it's ringing out like right here. If I want to do more upper lumbars, I would have her upper body right there without a lot of rotation, and I'd get my contact around the mammillary process and kind of ratchet her down and really rotate the lower part of her body and then just add a little bit of upper body torque in there. So notice the difference is her upper body's here with the upper lumbars, and for the lower lumbars it's going to be more like that. So it's not that much. We're talking like maybe 10, 15 degrees of rotation, but it's enough to take the tension and create a ringing out of the spine, lower versus upper. The middle is really easy. It's kind of 50-50 both. So if you can get uppers versus lowers, then that's good. The middles are really kind of easy. And the contact I want you to use is the hypothenar mammillary contact. I don't want anybody to use the spinous full contact right now. And you always want to use the contact you're going to manipulate with. So you wouldn't set them up like this and then switch to a different contact. So start with the mammillary process contact, get them here, and then you'll eventually just be able to kind of tweak the tension until they can feel it. And it should feel like subtle tension, not like, oh my God, my spleen's in first tension. So let's go ahead and try that. See if you can't rotate the upper versus lower lumbars and have your partner say, yeah, that feels like it's in my upper lumbar.